Good evening, our dear friends and viewers from CEC and all over the world. This is the fourth wave of the Best of ESC 2021. This is the final wave discussing the last one of the remaining guidelines, which is the guidelines of pacing, presented by Professor Mohammed Abshafi, Professor of Cardiology at Suez Canal University. And then I will follow this by a short briefing about four of the interesting trials that were discussed in the same conference. Dr. Mohammed Abshafi is an elegant speaker, and I'm definitely sure that we will enjoy the discussion with him about this pacing guidelines. So, Professor Mohammed, the floor is yours now.
Thank you, Dr. Mohammed, for the nice introduction. Thank you very much, dear friend. I'm very pleased once again to be using your respectable platform to present this presentation today. As always and forever, the issue of cardiac electrophysiology, starting from us being students studying arrhythmia in the undergraduate phase and following on and studying electrophysiology and pacing, it is always a heavy meal and a heavy burden to explain. So hopefully I'll make this light today. And heads up is that this presentation is going to be directed mainly at the level of a clinical cardiologist or otherwise cardiologist, not specifically at the affiliation of being electrophysiologist. What should they know about the new ESC guidelines for cardiac pacing and the new updates? So hopefully this is going to be a fruitful presentation and hopefully also followed by fruitful discussion. So the background today about this presentation is the topic we are going to start with, followed by two specific items. Of course, this is the core of the presentation, the updates in pacing guidelines, whether we are addressing evaluation or indication of pacing, as well as updates in cardiac resynchronization, and followed at the latest part of the discussion, special scenarios, a slide each, which we are going to discuss, through which special scenarios and clinical situations, specifically with the updates of using new devices and techniques like TAVI, with the high incidence of post-procedural AV block, when to pace and when not to pace. So this is like a summary of the updated guidelines, the specific updates in the guidelines, as compared to the oldest one, which was rather old. It was 2013, since we last had guidelines addressing pacing from the European Society of Cardiology. Pacing in TAVI, as we've mentioned, and also CRT indication, which has been expanded. Leadless pacing, we have a little bit of data for recommendation for leadless pacing. Bundle pacing, pre-implant evaluation, pacing for bradycardia. Of course, we are not going to address today pacing in patients with rare diseases. This is not the general concern of the general cardiologist. And high-risk reflex syncope as one of the presentation of bradyarrhythmia and how it's going to be addressed specifically as regard the indication of pacing in this category or this population. To start the background or the introduction, the epidemiology is that implantations are expanding. In Europe, there's a very versatile range of implantation per million persons, starting from Eastern Europe with the rate of 25 implantation per million persons, but in Western Europe, maybe due to better healthcare services or different demography, it reaches about 1,000 implantation per million persons. And of course, because of the advances in clinical health and the longevity of our population, the implantation has been increasing, because around 80% of implantation has been received by those above the age of 65 years of age, reaching about 1 million implantation in the year 2020 through 2021. The natural history of of this condition or for needing pacing, the most common indication, of course, by far, comprising more than almost 97 to 98% of the indication, is sinus node dysfunction and atrioventricular block. There is a core difference between these two conditions as regard the following two statements. Unpaced AV block patients have poor prognosis. That means that pacing increases longevity, and AV block patients, if left unpaced, specifically high-grade AV block, the definition of which we are going to mention, their longevity and their prognosis is poor and their longevity is compromised. And that is why when diagnosing such a condition, if persistent and has no reversible etiology, is an indication of pacing in itself, regardless of the symptomatic state. On the other flip of the coin, pacing does not improve survival in sinus node dysfunction. And thus, sinus node dysfunction, the indication of pacing in such condition, is totally relevant to the symptomatic state of the patient having these arrhythmias or sorts of dysfunction. And the indication is sure when we also link the symptoms, we are able to link the symptom to the timing of the arrhythmia. So this is a very major and core difference that will translate also into future recommendation that we are going to mention along the presentation. However, pacing universally improves quality of life in both indications. Whatever the indication of pacing, specifically dual chamber pacing, improve quality of life, decrease the incidence of AF that is being inflicted by pacing, the DDD pacing or the dual chamber pacing. So this is already settled. One of the new sections, although it's a small section in the new guidelines, it has no precedence before in the older guidelines, is gender differences and addressing it. And it's very simple. The main indication for pacing in females is sinus node dysfunction. On the other hand, the main indication by far in pacing in male patients, it's atrioventricular block. Complications are generally more procedural or peri-procedural complications are more in females, maybe due to smaller size and smaller venous size and diameter and smaller axis or harder axis. On the other hand, male gender carries a higher incidence of device-related infection. These are the main topics related to gender differences in the new guidelines. The definition is a very exhaustive slide. I don't want you to go through it right now. I'm not going to narrate it in full, but there are two definitions that I felt that warrant or for you to be on the same page while addressing such condition. Sinus node dysfunction is sinus bradycardia, bradycardia tachycardia syndrome, but sinus pause, it's important to address the sinus pause is absent of P waves for 2 seconds or more. That is the definition of sinus pause. So when I mention sinus pause, that is the definition, and it is very, very, very uncommon that in the range of 3 seconds or more, that is physiological or related to physiological condition like physical adaptation in highly trained athletes or so. On the other hand, one of the major or more important or most important definitions in atrioventricular is advanced or high grade or high degree AV block. Advanced, high grade, or high degree AV block. When we mention this, that means there are 2 or more consecutive P waves at a constant physiological rate that are not transmitted or conducted to the ventricle with evidence of some AV conduction. Of course, the latest statement is to differentiate between it and between 3rd degree or complete AV block, because we crudely mention advanced or high grade AV block as a sure indication later on for pacing in this condition. So the definition of this condition must be stated. The types of pacing, of course, we know we are not talking about the modes of pacing like DDD and DDR. We're not going to address this beyond the clinical cardiologist. But the types of thing that is being addressed here, what I mean is endocardial pacing, the general mode of action to pace the myocardium is through endocardial axis. Leadless pacing, we are going to mention the indication of leadless pacing, the battery and the contact myocardium in general is within a single device that is implanted in the RV apex. It has the battery and has the contact surface that is going to transmit the impulse at the same time. This is called leadless pacing, which is without a lead. Epicardial pacing, to go through it rapidly, is mainly indicated in those with very difficult venous access to the right ventricle or to the target position. And this is remarkable in two conditions: those which has been subjected to multiple procedure before and have multiple venous thrombosis and the vascular access is difficult. And the most commonly as well is those with congenital complex congenital heart disease, in which, of course, the anatomy and the vascular anatomy in particular is distorted. So access to the target sites is almost sometimes impossible. So an epicardial procedure, and that is mostly a surgical procedure, is the way to go. His bundle pacing is one of the alternative types of pacing that is deemed as being rather physiological. Physiological because pacing, in theory, pacing at this point, at the point of his bundle, will make the transmission of the electrical pulses through the ventricle, through the physiological conduction pathway, which will translate in lower conduction time in synchronous RV and LV contraction at the same time. It has been proposed as a replacement for those who in whom we are implanting a CRT or a CRTD, in whom coronary sinus access is rather difficult, or the patient has problem with coronary sinus access. And lastly, the type of pacing that is a different section on its own is CRT, which is cardiac resynchronization therapy. And this has a section of its own we are going to mention today. So let's start with the pacing guideline. It's mainly going to be divided into the evaluation, the part concerned with the evaluation of the patient and how we are going to address if the patient is indicated or not. And lastly, the indication of pacing in this particular group of patients. So the classification of bradyarrhythmias for which pacing is going to be offered, it's addressed in general is this flow chart. So patient will come with us with bradycardia-related symptoms. And these are mostly symptoms of low cardiac output in the form of fatigue, dizziness, lightheadedness, pre-syncope or syncope. If the patient has persistent bradycardia, the diagnosis is going to be straightforward. So with a simple ECG, since the arrhythmia or the bradycardia is persistent, is going to be diagnosed and categorized as either sinus node disease or some sort of AV block. If the patient does not have persistent bradycardia and need further prolonged monitoring, we are going to mention the tools of which later. It's going to be divided either there is going to be documentation of the arrhythmia, intrinsic arrhythmia, paroxysmal AV block, the paroxysmal forms of the arrhythmia, sinusoidal block and sinus arrest, atrial fibrillation with slow ventricular condition, or suspected. The presentation is going to be highly suspicious, and the patient has underlying bundle branch block, which is like a need us for a possible some sort of higher degree of block that might be a patient's condition. If the history suggests a reflex syncope, as we're going to mention, the patient is going to be further tested with carotid sinus testing and tilt testing to show tilt-induced symptoms or carotid sinus massage-induced symptoms. And unfortunately, we are going to settle with some patient with unexplained syncope and unexplained symptoms if all these workups came back negative. The tools by which we make this evaluation are very simple tools. History taking is very important to address the cardiovascular risk of the patient and concomitant comorbidities, because specifically in sinus node dysfunction, this is what dictates the prognosis. Sinus node dysfunction in itself does not carry or harbors a poor prognosis in itself, but the underlying risk, general cardiovascular or comorbid cardiovascular disease, is a thing that is most important. Complete history focusing on symptoms. The general history, the frequency of the attacks, the severity of the attacks of like falls or syncope or pre-syncopal attacks is very important. The presence or absence of prodromes or inciting that is, of course, family history is very important. and medical treatment. Revising the patient's medical treatment is very important, and we are going to go, and this has been focused a lot on in the spacing for possible reversible causes of either S-node dysfunction or AV block, the medical treatments and the medication that the patient is receiving. Physical examination, of course, complements the history in addressing the same targets. The peripheral circulation, the cardiac examination that must suggest etiology. ECG, of course, is very important, but of course, the word ECG here does not only address resting 12-lead ECG, but also prolonged monitoring, and this is going to have a slide of its own. And of course, cardiac imaging, the class 1 indication of which is echocardiography, because addressing if the patient has structural heart disease of some sort of disease like infiltrative disorders or so might suggest the etiology and might suggest whether reversibility of the condition or not. Ejection fraction evaluation is very important because in the expanded indication of CRT, as going to mention, is very much related to the ejection fraction, even in the asymptomatic patients who are going to receive a pacemaker for another indication or ICD for another indication. The upgrading of the device into a CRT is very important in patients with low ejection fraction. The medication we are going to address in the history are a lot, and almost all of them has effect on both sinus node function and might incite AV block. I'm going to mention those with preferential effects on only one of those. In the antihypertensive group, we have methyl dopa and clonidine predominantly affecting the sinus node. They have the AV node. It's very important to recognize that all antiarrhythmic drugs, apart from procainamide, have effect on both the AV node and the SA node. Procainamide alone has effect only on AV node and might incite AV block, but has no effect on the sinus node. This is a very important point. And of course, ivabradine, by its mechanism of action, it's understandable that it affects only the sinus node. Antipsychotic and neuroactive agents also selective serotonin uptake inhibits the SSRIs, tricyclic antidepressant, very widely used drugs. It's predominant, it's common drugs that we are used, specifically ours, ticagrelor, because of the abundance of adenosine in patients receiving ticagrelor, might have effect on both. And we have agents like proton pump inhibitors, predominantly causing sinus node dysfunction, as well as muscle relaxants, as well as high dose corticosteroid. On the other hand, H2 antagonists can affect both. The conditions also, whether we are talking about cardiovascular condition, cardiomyopathies, neural conditions, sleep disordered breathing, or sleep apnea syndrome, and all of the cardiac conditions are affecting. Again, I'm going to focus on those preferentially affecting a single agent involved without sparing the SA node. And among the cardiac procedures, the MACE procedure affects only and spares the AV node. Date evaluation or how to treat patients. It's very important to address then once a month unexplained syncope or other symptoms related or suspected to be caused by bradycardia, in whom a comprehensive evaluation, and the comprehensive evaluation we've mentioned and are the aforementioned four tools. The resting clinical examination, the history taking, the imaging did not demonstrate a cause. A long-term ambulatory monitoring with an internal or implantable loop recorder is recommended because this device might record the cardiac rhythm for years, and this is a class 1 indication. Ambulatory electrocardiographic monitoring is recommended in the evaluation of patients with suspected bradycardia to correlate rhythm disturbance with symptoms. Not only the implantable loop recorder, we have a lot of other devices or tools that we can mention, because in a lot of the arrhythmias, the indication of pacing is dependent not only on documenting the bradycardia, but also relating it to the symptoms. This is a very important slide because we are exhaustively and with a futile nature exhausting our Holter ECG in such condition. A lot of our patients has rather infrequent symptoms, and on daily basis we have to order a Holter monitor. Despite that, we have to have very frequent episodes of the complaints we are suspecting to be due to bradycardia in order for us to order the Holter monitor. So at least 3 to 4 events per week will justify using Holter for evaluation or primary evaluation of patients that do not have persistent bradycardia. If the condition is recurring every month, an external loop recorder and external, now we have ECG patch without without even like electrodes or separate electrodes that can go on for a month or even more, that can record for prolonged periods of time. But as in the aforementioned slide, if the patient has very infrequent symptoms, less than 1 episode per month, implantable loop recorder is the way to go. Carotid sinus massage or carotid massage, once carotid stenosis is ruled out, of course, we have to know that there are some contraindication to this technique, which if the patient have previous TIA or stroke, or have a carotid bruit and documented stenosis on Doppler, they cannot undergo this test. Once all of these are excluded, carotid sinus massage is recommended in patients with syncope of unknown origin, but with a history compatible of a reflex mechanism. There is a precipitating factor, the prodrome, specifically if it's related to pressure or manipulation of the carotid sinus area, such as bending the head, such as tying a tie, such as shaving or so. Events like this that are suspected, this is a class 1 indication. Till testing has been upgraded again from class 2B from the previous syncope guidelines to class 2A here, should be considered in patients with suspected recurrent reflex syncope. And this is very important, and this upgrade is related to the fact that it is decisive in dictating a sure indication of pacing in patient with recurrent reflex syncope, because a cardio-inhibitory response or in tilt-related systole is rather a class 1 indication for pacing in such category of patients. Exercise testing is recommended in patients who experience symptoms suspicious of bradycardia during or immediately after exertion. In patients with suspected chronotropic incompetence as well, it has a class 2A indication in order to document and confirm this diagnosis as the cause of the patient symptoms. And the class 2B indication in patients with intraventricular conduction disease or AV block of unknown level. Exercise testing might unmask an infranodal block that will warrant pacing for such particular patients. Cardiac imaging, as we've mentioned, is very important to document the presence of structural heart disease, left ventricular function, potential causing of conduction disturbances like amyloidosis or so. And this is in the form of echocardiography or TTE. Multimodality imaging in those patients with in whom we need to specify or diagnose specific pathology like infiltrative diseases or so, particularly those with conduction block younger than 6 years of age, might be warranted if also the primary comprehensive examination and evaluation did not reveal function, potassium levels, electrolytes, and so on are a mandate, of course. And sleep evaluation is very, very important. Screening for sleep apnea syndrome is recommended in patients with symptoms of sleep apnea syndrome and in the presence of severe bradycardia or advanced AV block during sleep. So if a patient with a Holter monitor or loop recorder or so, the documentation of the arrhythmia specifically during sleeping, this is very important to do such a study, because it's going to be responsible for a lot of these events. And addressing this patient with weight loss and CPAP therapy almost abolishes more than 80% of the bradycardic events that occur in this patient. So this is very important to document in this particular group of patients. EP study, when to refer, when it is important. This is very important. In patients with syncope and bifascicular block, EPS should be considered when syncope remains unexplained after non-invasive evaluation, or when an immediate decision about pacing is needed due to severity, unless empirical pacemaker is preferred. So sometimes when a patient has advanced bifascicular block and symptoms of syncope or pre-syncope, in whom otherwise other etiologies cannot be documented, frail patients or elderly patients who are not going to be subjective for this, and it's justifiable to do empirical pacing in those, will not undergo this study, but in order to document an advanced and more higher grade of block in this particular group of patients, it is warranted as a class 2A indication. Genetic testing in young patients with very progressive cardiac conduction disease, in whom the condition happens very quickly, it's warranted as a class 2 indication. Also, genetic testing should be considered in family members following the identification of a pathological genetic variant that explains clinical phenotype of cardiac conduction disease, and in index case. It means that the index case is the one coming with a complaint in whom a genetic or a genotype has been addressed and has been diagnosed as a cause of the patient's condition. Family members might be subjected to genetic testing as well. Moving on to the pacing indication in this particular group of patients, we are going to divide it in sinus node disease and, of course, atrioventricular block separately. As we mentioned earlier, due to the nature of or the natural history of sinus node disease, in the terms that it's not or does not carry an inherent risk of poor survival or poor prognosis in its own, so symptoms and linking the symptoms to the bradycardia is very, very, very important, and the threshold in for pacing in these conditions is relatively high. So in patients with sinus node dysfunction and a dual chamber pacemaker, minimization of unnecessary ventricular pacing through programming is recommended. Why is this recommendation important? Because those patients do not have AV block if the primary condition is sinus node disease. So even when they have DD pacemaker and a ventricular pacer and an appropriate EV conduction, so atrial pacing is enough, and minimization of ventricular pacing is very important in order to decrease the synchrony and the effect on LV performance and ejection fraction on the long term that is compromised in above 20 to 25% of patients with persistent RV pacing. Pacing is indicated in sinus node dysfunction when symptoms can clearly be attributable to the bradyarrhythmia. This is very, very, very important for the pacing to have a class 1 indication in this category. Pacing is indicated in symptomatic patients with brady-tachy form of sinus node dysfunction in order first to correct the bradyarrhythmia in general and to enable pharmacological treatment, unless ablation of the tachyarrhythmia is preferred. Because if the tachyarrhythmia can be preferred and we don't have to give a drug to tackle this tachyarrhythmia, and the bradyarrhythmia or the bradycardic side of the coin is not that symptomatic, the patient might be spared from pacing. In patients who present with chronic tropic incompetence and have clear symptoms during exercise, also DDD pacing or dual chamber pacing with rate responsive pacing should be considered to match the physiological needs of the patient during exercise. AF ablation should be considered as a strategy to avoid pacemaker implantation as well. This is like a continuation of the previous brady-tachy element in whom patients can undergo ablation. Also to spare a patient from having a pacemaker, specifically if the bradycardic events are related to the AF. After AF conversion, a lot of patients have what is called pre-automaticity pause, a pause before restoring the inherent sinus node automaticity, and this might be prolonged and very symptomatic in patients with paroxysmal AF, so ablation of the arrhythmia might suffice. In patients with brady-tachy variant of sinus node dysfunction, programming with atrial anti-tachycardia pacing might be considered. I want to spare this slide only to go to the last indication, which is the class 3 indication. Sorry. Pacing is not recommended in patients with bradyarrhythmias, again, related to sinus node dysfunction that are asymptomatic or due to transient cause that can be corrected and prevented. Of course, the last half is very, very understandable, but symptoms are very important. We are not improving the patient's prognosis with pacing. We are just improving quality of life. So if the patient is either symptomatic or the symptoms are clearly due to other cause other than sinus node dysfunction, pacing is not warranted in this population. On the other hand, pacing AV block is a different animal. As we mentioned, pacing is indicated in patients in sinus rhythm with permanent or paroxysmal advanced block like third degree or second degree type 2 infranodal or high degree AV block, irrespective of symptoms. Now we are introducing a device that improves prognosis and prolonged longevity. So symptoms here are irrelative if we have a high degree of block. Pacing is indication in patient with atrial arrhythmia, mainly AF, and permanent or paroxysmal third or high degree AV block. So whether the patient have a high degree AV block on the background of AF or sinus rhythm, both are class 1 indication for patients. In patients with permanent AF and in need of pacemaker, ventricular pacing with rate response function is recommended. Since the patient has no atrial activity, a single chamber pacemaker with ventricular lead is going to be implanted, and it's preferred. This patient has a class 1 indication to have a rate responsive pacemaker for those patients. Pacing should be considered in patient with second degree type 1 AV block, which we are called wing back block, if it's located at an infra-ECL level, either with the surface ECG or even if it was revealed with EPS study. In patient with AV block, dual chamber should be preferred over single chamber in those, of course, in sinus rhythm, for the sake of avoiding pacemaker syndrome and to improve quality of life. Permanent pacemaker implantation should be considered for patients with persistent symptoms similar to those of pacemaker syndrome and clearly attributable to first degree AV block. So even patient with first degree AV block with a high grade PR interval 0.3 seconds or more and have symptoms of fatigue and extreme physical intolerance like those with pacemaker syndrome, it's a class 2A indication to insert a DDD pacemaker. And at last, pacing is not recommended in patients with AV block due to transient causes that can be corrected or prevented. Pacing in reflex syncope, it's very important. This is a very important approach. Management of cardiac pacing reflex syncope, to start with, in order to consider pacing altogether, we must have two conditions: that the patient's age is above 40 years of age and he have severe recurrent unpredictable syncopes. So even in order to explore a cardiac inhibitory response that might respond to pacing in these patients, they have to have both these conditions: that severe recurrent unpredictable syncopes in which health education and preventive measures are not going to suffice, and the age above 40 years. So if none, of course, there is no need for pacing, but if yes, first, because we have already a history suggestive of reflex syncope, perform carotid sinus massage until table testing. We're going to start first with a carotid sinus massage. If a carotid sinus massage elicits a cardio-inhibitory carotid sinus syndrome, which is more than 3 seconds of pause accompanied by symptoms, this is going to be an indication for pacing on itself. But if you can observe, there is an intermediate test even if the patient has cardio-inhibitory carotid sinus syndrome. But if you look very, very carefully, this will not affect the decision of pacing. So either a positive tilt table test when we do it after the carotid sinus test, in both pathways, even if it's positive or negative, there is going to be an implantable dual chamber pacemaker. And the indication in these patients when we are performing the tilt test is to elicit a vasopressor or a hypotensive response, because additional hypotensive response in those with positive tilt testing will warrant that the patient, beside the implanted device, might have a benefit in counteracting hypotensive susceptibility and have indication for drugs and maneuvers that attacks this hypotensive susceptibility. But all of them are going to benefit from a pacemaker. Of course, if the patient doesn't have this inhibitory response but have asystolic tilt test, not the hypotensive response, the asystolic response, also dual chamber pacemaker is going to be implanted. And at last, if both of these tests is negative and the patient will undergo then an implantable loop recorder and it came back positive and asystole or severe bradyarrhythmia is elicited, so in this case an implantable dual chamber pacemaker as well is going to be offered for this patient. And as we've mentioned, if there is no asystole, no response to tilt table testing in carotid massage, or the patient to start with is either younger than 40 years of age, or the syncope is predictable and preventable and not frequent or severe, pacing is not indicated altogether. Moving on to CRT. The indication is very, very clear for those in sinus rhythm with left bundle branch block morphology and ejection fraction below 35%. Of course, it's non-correctable or not due to correctable causes like valvular heart disease or early on post-MI and so on. If it settles below 35%, and the QRS duration, left bundle branch block morphology, QRS duration above 150 milliseconds is a class 1. the same recommendation exactly, but above 130 to 149 milliseconds of QRS duration, because the rate of response is relatively lower, so it's a class 2A indication. On the other hand, when we are addressing non-left bundle branch block QRS morphology, a wide QRS complex, which is not definitely left bundle branch block, either right bundle branch block or non-specific conduction delay, the class of indication drops by 1. So in those above 150 milliseconds, this is class 2A. In between 130 to 149, it is class 2B, may be indicated. And lastly, it's not indication patient heart failure with QRS duration below 130 milliseconds whatsoever. There is no indication in such group of patients. In atrial fibrillation patients, AF patients with heart failure and the need for CRT has two perspectives. First, from this slide, the perspective of the patient with already heart failure and low ejection fraction, in which we are discussing CRT or CRTD or whatever the device, because the patient failure and the CRT device to start with. We are going to understand what I mean when we go to the next slide. But here, let us go on. The first part, the class 2A indication, the same indication, those above 130 milliseconds QRS complex, left ventricular ejection fraction below 35%, and with atrial fibrillation and still symptomatic on treatment, are going to be offered a CRT, even in atrial fibrillation, in order to improve symptoms and reduce morbidity and mortality. One additional piece of indication is that AV junction ablation should be added in case of incomplete biventricular pacing. The success of CRT or biventricular pacing is conditional upon the success of having biventricular pacing that is going to achieve or to restore the lost synchrony in this patient in more than 90% of the situation. If AF, due to rapidly conducting atrial waves, distort this biventricular pacing and the pacing is below 90%, AV junction ablation is indicated as a class 2 indication in this patient when we are offering them CRT for a heart failure indication. On the other side of the coin, there's another aspect, recommendation in patients with symptomatic AF and uncontrolled heart rate who are candidates for V junction ablation. So this is from the perspective of the AF. To start with, these are heterogeneous group of patients. We are not addressing the heart failure indication of CRT now. This is just asymptomatic patients with AF, in which the symptoms are greatly related to AF and cannot be controlled. The AF rate cannot be controlled with medical treatment, and the patient has been deemed as a candidate for AV junction ablation. How to proceed if we are going to ablate this patient, who is going, of course, to need a pacemaker in order to pace the ventricle. So in patient with already HFrEF, the patient happens to be, by chance, having heart failure with reduced ejection fraction, regardless of the symptomatic state. This is very important because this will differentiate this recommendation from the last one, from the patient who are still symptomatic with low ejection fraction. No, this is a patient heart failure with reduced ejection fraction, whether he's compensated or not. It's a class 1 indication. In the mid-range, or we are calling now mildly reduced ejection fraction between 40 and 49%, it's a class 2A indication to have a CRT rather than a standard RV pacing. But the RV pacing should be considered standard when you are going to pace these patients after AV junction ablation if they have heart failure with preserved ejection fraction. So when to upgrade or when to start with a CRT even for a pacing indication. So patients who have received a conventional pacemaker or an ICD and who subsequently develop symptomatic heart failure with left ventricular ejection fraction below 35% despite optimal medical treatment, and who have significant proportion of RV pacing should be considered for upgrade. So the patient have a pacer. The pacer, due to high grade of RV pacing, has developed either due to RV pacing itself or concomitant condition, heart failure with low ejection fraction below 35%, not responding to medical treatment. The pacemaker or the device or the system should be upgraded to biventricular pacing or CRT. CRT rather than RV pacing is recommended for patients with heart failure with reduced ejection fraction below 40%, regardless of NIHA class. So if a patient have an indication for a pacemaker, or an ICD or whatever, in which there is anticipated high grade of RV pacing, and the patient is not symptomatic but has an ejection fraction baseline lower than 40%, the patient from the start, it's preferable to be offered a CRT rather than having the regular RV pacing or the pacemaker, regular pacemaker. CRTD or CRTP. CRT means CRTP is without a defibrillator with the regular pacing capabilities. D or CRTD is having defibrillator capability. In general, CRTD is preferable. Of course, it's +1 indication in those already having an indication for a defibrillator, and those who do not have clear indication but are going to be offered a CRT, it's preferable to be a CRTD. What is against is as follows. A great degree of myocardial fibrosis favors CRTD, and a relatively lower age favors CRTD. Lack of myocardial fibrosis and increased age or frailty or so on is of course in favor of CRTP sometimes. And there is of course a discussion with the patient. Other factors might favor, like patient preference, non-ischemic cardiomyopathy, short life expectancy, major comorbidities. So the simpler procedure with the simpler device is going to be offered patient preferably than CRTD. What are the special scenarios we are going to address? A patient who will need watchful waiting. This that happened during cardiovascular acute condition or post-procedural like AV block and sinus node dysfunction. So we'll start with AV block after TAVI. AV block after TAVI is very, very little tolerated because the pathophysiology is totally mechanical, related to the pressure of the valve, of the implanted valve, which is, we know of course that the aorta is a part of the aortomitral continuity, in which it has great proximity to the AV node and the His bundle, and this is direct mechanical pressure that is not expected. This is as a pathophysiology or a mechanism is not reversible, so we don't tolerate AV block after TAVI for a long time. If it's irreversible within only 2 days, so this is an indication of pacing in this particular group of patients. How about AV block after acute MI? This is the new like time frames in which you are going to tolerate AV block after either acute MI or after cardiac surgery like valve surgery or so. Only 5 days. 5 days is going to be given to these patients for possible reversibility, after which if the patient has persistent high degree of AV block, according to the regular elective situation, are going to be offered permanent pacemaker. On the other hand, sinus node dysfunction or chronotropic incompetence after cardiac surgery of cardiac transplantation, because the reversibility is possible after a long time, and because we are not addressing a condition which is detrimental to prognosis or longevity or mortality, so it is very, very much well tolerated. You can wait up to 6 weeks in those two conditions before even beginning to consider pacing for these patients, and this is a like a continuum of the inherent differences between sinus node dysfunction and AV block and their relation to prognosis. How about the indication of lead lip pacing? It has no class 1 indication yet, but the class 2 indication, or its main indication, it should be considered as an alternative to transvenous pacemakers when no upper extremity venous access exists, or when the risk of device pocket infection is particularly high, specifically in those with previous infection. Of course, in patients who are most commonly going to demand a single chamber pacing through the RV apex. What about His bundle pacing? When to pace the His bundle? We don't have class 1 indication. The class 1 indication here is related to a technical aspect, which is device programming tailored to specific requirements related to electrophysiologists. But as regarding the indication, it's the in whom coronary sinus lead implantation is unsuccessful. His bundle pacing, which is going to activate through the His bundle and physiologically through the bundle branches with simultaneous ventricular activation, is going to be offered to these patients and should be considered as a treatment option along with other techniques such as surgical epicardial leads. This also is another indication for epicardial leads. The last indication here is not indication of His pacing, but it's in the class 2A indication, is the indication of implanting an additional backup RV lead in those patients because the failure specifically if the patient has an indication for pacing as well, not just for heart failure, and pacing is mandatory because there is some sort of relatively high failure rate of his bundle pacing, that the lead might dislodge or the capture might be lost, and a backup RV lead should be implanted when we are performing this type. Of course, this is an issue, an always discussed issue. In patients with MRI conditional pacemaker systems, MRIs can be performed safely following manufacturer instructions. On the other hand, in patients with non-MRI conditional pacemaker systems that are not compatible inherently with MRI should be considered if no alternative. It's conditioned upon two things: no alternative imaging mode will help the patient, and also if there are no epicardial leads. So epicardial leads are prohibitive to MRI in general. If there are no abandoned or damaged leads, or lead adapters extenders are present, means like no debris of previous device is present and no epicardial leads. Only then can we perform MRI in patients with non-MRI conditional pacemaker. How about TAVI? In those undergoing TAVI, there are a lot of conduction abnormalities that happen, but the one that warrants pacing, there are two conditions which will warrant permanent pacemaker with a class 1 indication, that the patient has persistent high degree AV block after the condition that lasts for more than 2 days, as we have mentioned, or new onset alternating bundle branch block. A class 2A indication is patient with pre-existing right bundle branch block who are going to develop atop of this right bundle branch block new post-procedure conduction disturbance. Other types of conduction deficits will warrant ambulatory monitoring and might also warrant EPS study, but will not be a direct indication for pacing. Lastly, this is the last slide, the infection prophylaxis. Of course, a part of the device, cardiac implantable electronic device infection, the treatment of which is beyond the scope of this presentation. It's already present in infective endocarditis, either prophylaxis treatment, but few tips, simple tips, is the administration of preoperative antibiotic prophylaxis within 1 hour of the skin incision is recommended to reduce the risk of infection in this population. Cefazolin 1 to 2 grams half an hour to 1 hour before the procedure is all that we need. The injection of antibiotic, either powder or gentamicin or so, has no effect on reducing the incidence of infection, and post-procedural antibiotics has no relation to reducing the incidence of infection. Of course, this is without saying, besides the very sterile condition, the sterile surgical techniques and so on is very important, but the only role, documented role for antibiotic is before the procedure by 1 hour. Chlorhexidine alcohol instead of povidone iodine alcohol should be considered for skin antisepsis. This is also superior and by trials has been tested. Rinsing the device pocket with normal saline solution before wound closure should be considered as well. And lastly, it may be used in patients undergoing a re-intervention for an electronic device. The use of an antibiotic eluting envelope might be considered. And with this, I end my presentation with this comic. All of us want to be this patient who is not needing to have exercise because of his pacemaker, because we can program the pacer to do the exercise for him. And thank you very much.
Thanks a lot, Dr. Mohammed, for this great discussion and this outstanding overview of the guidelines of cardiac pacing, which is usually a heavy topic for the undergraduates and the postgraduates to study.
Yeah.
But I think you elaborated
that way.
in a nice way, starting by the changes and then going into the depth. And I think also that this version of the guidelines has been written much easier and much more palatable than the previous versions. What grabbed my attention in your presentation is that the tilt table test has been returned back to the guidelines. Yeah. Previously, it was a little bit downgraded, but now I think it receives a class 2A, maybe because it helps in the diagnosis and the differentiation between the two most common types, the cardioinhibitory and the vasodepressor syncopes, and sometimes it may indicate cardiac pacing. But I would like to ask you a little bit in depth about the role of beta blockers in the vasovagal syncope, the role of vasopressors like midodrine and stuff like this oral drops used by our patients. Maybe I would like you to give a 1 or 2 minutes hint upon this specific type of syncope.
The particular group of patients who benefit from drugs specifically like midodrine or so are not the direct vasovagal syncope patient, but is rather those with orthostatic conditions. They benefit, or the class of indication is higher. It's class 2A, and in the general pool of population with the reflex syncope, it's rather class 2B. What's most important or more important is the education, the exercise that the patient might exert in order to reverse the vasopressor response that happened in vasovagal syncope, the situation, revising the situations and avoiding the situations in which are inciting or precipitating for the reflex or vasovagal attacks. This is very important, but the role of the drugs is there. Still, it can be present, and the role of drug is important in those population with infrequent attacks, with frequent attacks, but with less severe attacks, and in those below 40 years of age. So those who have infrequent attacks and below the 40 years of age, and these attacks are not severe, specifically if they underwent tilt-table testing, it was elicited only vasopressor response, still there's a class of indication for midodrine in this population of patients. They might benefit, but the class of indication is higher in those with orthostatic hypertension.
Thanks a lot, Dr. Mohammed Abshafi, for this wonderful presentation of the guidelines. And I think now we need to move to the second part of the webinar tonight.
Yeah.